Good afternoon. My name's Dave. I'm one of the senior radiation engineers for the Kent Oncology Centre based out of Maidstone and Tunbridge Wells Trust. And yeah, I'm here today to talk to you a bit about flash radiotherapy. It's a new technique that's currently very experimental. So just trying to sort of bring awareness to the wider radiotherapy and healthcare science communities about this exciting development. So let's begin. So what is flash radiotherapy? In a nutshell, it's giving your dose of radiation in a very, very short time. So flash radiotherapy, sometimes referred to as flash RT, is using a process referred to as ultra high dose rates. So our dose rates are incredibly high compared to conventional radiotherapy when we're using flash. Conventional tends to be about 0.5 to 5 grays per minute, where flash radiotherapy is over 40 grays per second. So an order of magnitude higher. This whole process relies on something called the flash effect. This is what makes this medically and scientifically an interesting technique. But what is this flash effect? Well, while the term flash RT has only come into use in the last 10 years or so, originally the flash effect was discovered in the late 50s. What they found was ultra high doses of radiation given very, very quickly seemed to have a protective effect. This was first used on bacteria and then on mammalian cells. You can see a little timeline to the right of the slide there. After testing on cells, they moved on eventually in 2014 to testing this on mice. Previously, a lot of the equipment that was available wasn't very suitable. And in the recent sort of decade, some of the equipment that's out there can be modified to deliver these flash beams, these incredibly high dose rates. The interesting thing they found was this protective link was somehow to do with oxygen consumption. The flash dose rates tend to, in effect, burn up the oxygen in the tissues, and somehow this was also creating a protective effect in those cells. They tried this on mice in 2014, and they found that when treating lungs and brains, the lungs exhibited a lot less fibrosis, and there was a lot less brain damage in mice that were given flash dose rates. They experimented a bit at the time and played around with the dose rates and the dose itself, and got a good idea that over 40 grays per second, this incredibly fast dose rate was what was creating this protective effect. You can see on the timeline there that there was a treatment done in 2019, which we will talk about in a later slide, and a clinical trial has been performed, which again we will talk about as the presentation progresses. So we've seen that this high dose rate is protective of cells. So why would we use it? Well, while it was protective of the mouse's lungs and brains in experiments, it still maintained a therapeutic effect on tumor tissue. When you add in the fact that you're giving an entire course of treatment in a single fraction of a second, there is a lot of time savings to be had there, as well as this prospect of protective effects of healthy tissue. So combining those, this becomes a rather attractive avenue of treatment. We could treat patients a lot quicker and a lot safer if we can prove this flash effect is as good as it seems to be. You may wonder then, how does this flash effect work? Well, it's still so new, we're kind of running on theories and ideas. The leading theory at the minute is this oxygen depletion effect of flash. And the diagram on the right of the slide there, you can see this represented. With the flash, there is less O2 in the vasculature, which means less reactive oxygen species are created. These react with the healthy tissue and are toxic to it. So as you can see in the conventional side, there is a lot more of these reactive oxygen species and a lot less in the flash. There are other theories, though. Some say that they believe the flash delivery of radiation creates less DNA damage. There are less double breaks in those DNA chains. And another theory is that hydrogen peroxide products are created by the flash delivery. Now, these can be a lot more easily removed and dealt with by healthy tissue than by tumours. So effectively, the extra hydrogen peroxide poisons the tumours further. They have taken this to clinical study, and they have very recently, in fact, in 2020, performed the FAST-01 clinical trial. So in this trial, they had a number of individuals, 10 of them, 10 patients. They treated 12 sites in total, and the patients were aged between 27 and 81 years old. There was an equal split of male and female participants. 8 grades of radiation were given. Now, normally this would be an entire treatment given over several fractions, maybe up to 20 fractions. This was entirely given in one dose at flash dose rates, so over 40 grays per second. They used this to treat bone cancer in the extremities. This was considered palliative care. All of the patients were undergoing palliative care, so this was chiefly for pain management. They used a proton therapy system. This had to be modified, and this was over in Cincinnati Children's Hospital that they did this. And they treated. There was no issues with the equipment. It all worked fine, and all of the patients received their treatments. They were then monitored for some time afterwards. So the results of this trial came in, and you can look these up online. They're actually incredibly promising for the viability of this technology. The primary thing to remember with the FAST-01 trial is it was for workflow feasibility. That was its primary purpose. But of course, they did want to see the therapeutic effects as well as the side effects from giving this new treatment. On the right here, you can see a little table with the adverse events that they put down for it. These are all graded in the usual radiotherapy systems, where grade 1 is the least severe grade. And as you can see on that, there was very few side effects, and they were pretty much all very much low graded side effects. So this is in line with conventional radiotherapy. The flash therapy showed that it had no greater side effects, and in some cases actually had slightly less severe side effects. As far as the workflow feasibility went, the average time on the couch was 18.9 minutes, so a little bit longer than we get in our centres at the minute. The average time per treatment site was 15.8 minutes. So with 12 sites and 10 participants, there was some that had more than one site treated. Of those treated, the transient pain flare cropped up in 4 of the 12 treatment sites. Again, this isn't particularly unusual for conventional radiotherapy and was nothing that concerned the researchers at all. The patients reported pain relief in 8 out of the 12 treatment sites, which is fantastic. And most encouraging of all, there was a complete response, so no pain afterwards in 6 of the 12 sites. I'm sure if you're coming to your end of life and you have a painful bone cancer, having the pain taken away out of it is going to improve what time you have dramatically. So that was a fantastic result. It would seem that the FAST-01 trial showed that the workflow feasibility was good, the effects were good, and the side effects were good. So you may wonder why all of the manufacturers aren't rushing off to build their own flash RT systems. Well, that's because there are unfortunately some technical difficulties. As I mentioned earlier, it's only become possible recently to be able to modify existing systems to produce flash dose rates or ultra high dose rates. But that's not the only technical issue. So there is technical issues with dose measurement, there is technical issues with targeting, and with the beam production itself. So I'd just like to take a moment and go through each of those issues and sort of talk about them a little bit. First off, dose measurements. Well, the ion chambers we currently use in systems like our Varian true beams would become saturated very quickly by flash RT dose rates. So they're not going to cut it. So we have to look at some other options. Well, we can look at silicon-based sensors. These work very well for photons, but they become limited at the lower end of the dose range when you're treating with electrons. There are chemical dosimeters. Oh, excuse me. Unfortunately, with these, you tend to get a final result out of them. They'll give you your dose, but that's about all the information you can get. There are Cherenkov detectors. Now, these work quite well for this use. They use a radiator. The radiation passes through it and produce Cherenkov radiation, which produces a sort of low light intensity. This is then monitored and you're able to calculate your dose rates from the light. There is also a scintillation-based detectors. These are very similar to the Cherenkov, but they use a slightly different system to produce the light, and the time resolution of those aren't as good. It's a lot more instantaneous with the Cherenkov detectors. And then finally, there's a couple more that could be used. These are luminescent type detectors. I'll pop them both up there. These can be good, but unfortunately, they take the dose and then they have to be processed to release light, which is then converted into the dose measurement. So these aren't particularly useful for the middle of the treatment, but could possibly be used afterwards in a QA sort of role when they're verifying that treatments were delivered correctly. There is also, not on the slide, some work going on in the UK at the Diamond Light Source. They have taken an interest in this dosimetry problem, and they are looking into diamond-based photocells that they have found can handle the fast dose rates and the large charges that are involved with flash RT. So it looks like we are getting close to solving the measurement issue, but that leaves us with the issue of targeting and beam production. So we'll talk targeting. If we're giving an entire course of treatment in a fraction of a second, it is absolutely vital that we don't miss any of that tumour. We can't be leaving any of those cells untreated and able to reproduce. That said, if we can prove to a really good satisfactory level that this protective effect is solid and reliable, we could actually afford to increase our field sizes just a bit. Okay, we would be catching more healthy tissue in that, but then we can rely on the protective effect of flash to protect that healthy tissue and make sure that we capture all of that tumour in our treatment field. So we can possibly target okay, we could possibly in the future monitor okay, but we still have to produce the beam, and that at the moment is probably one of the more difficult issues that needs to be solved. So far, they have used TrueBeam and Clinac systems from Varian that have been modified for a lot of the laboratory testing. Earlier on, I mentioned the first human treatment. That was done on a prototype system specifically constructed to deliver electrons in flash RT mode. Now, this treatment was on a 75-year-old patient who had a tumor, a skin cancer, and he'd already received over 110 radiation treatments to the site. It was at this point they couldn't give any more conventional radiotherapy. It was becoming too toxic. So they tried in desperation flash, and they actually found that it was effective. It had a great therapeutic effect and a lasting therapeutic effect in controlling the tumor without directly increasing the toxicity that was already in the healthy surrounding tissue. And there is the clinical trial that went on a few years back, and for this they used a modified proton system. It's likely, though, in the future that we are going to need custom machines. Perhaps the custom machine would be a modified version of one that's currently available, especially if we're talking electrons as your beam. But ultimately, to really get the best benefit out of Flash RT, we're going to need machines specifically constructed and designed to deliver these really high dose rate treatments. There are a number of beams we can use. We've mentioned protons, photons, and electrons so far. So I'd like to talk about each of them. But before we get too deep into a specific one, I'd like to bring your attention to the graph on the right of the slide. Now, this is a dose depth graph, and this is showing you where the dose of your beam is highest at what depth. This is in water and is about the same for the human body, us being mostly water. At the left side of the graph, you can see electrons, X-rays at 100 keV and X-rays at 6 MeV. The electron line, the yellow line, as you can see, it deposits its dose quite shallowly and then drops off dramatically. Now, this is fantastic for treating tumours on the surface, but is no good for getting deep into the body. You can see the X-ray ones, while they peak similar to the electrons, they maintain that dose as the depth goes on. And sweeping across the top there, which we'll come to in a later slide, is a 70 MeV electron beam. This is also referred to as a very high energy electron, VHEE. On the right side of the graph, we have some interesting Bragg peaks, as they're called here. One is for photons and one is for heavy ion, which is generally a carbon ion. Here it's carbon 12. Now, these are fantastic to use for treating tumours because, as you can see, they deposit their dose nearly entirely at a specific depth and then drop away very quickly. So this minimises the radiation exposure to tissue along the beam path before and after the tumour. I'm not going to cover heavy ions too much in this, as they themselves are quite a new technology that is used primarily in Japan, who have sort of pioneered these techniques, although there are a few centres now in Europe and plans to open centres in the US. Protons is, of course, what they used in the trial and is a very effective method of treatment, but it does come with some rather severe financial considerations, which we'll come to. So let us start with photons. They give a good depth penetration and they can treat the surface and deeper, but producing them is a quite inefficient process. For anyone who's not in the radiotherapy world, we first have to accelerate an electron beam, which we then stop with a tungsten target. And this, through Bremsstrahlung radiation, creates X-rays, and this is then shaped into a field for treatment. Unfortunately, though, a lot of the energy that we put into those electrons is lost through heat and other mechanisms as it's converted into the X-rays. So we would need a beam in the region of 1,000 times more powerful than what we can currently produce to get photons at flash dose rates. Obviously, that is a technical limitation that's quite hard to currently surmount. It's yeah, that's going to be a tricky one, and is a good reason why all of the experimentation so far has used electron and proton beams. So talking of electrons, going straight into it, these have been used for testing in both laboratory. They were used for the first ever human to receive Flash RT, and they can be made fairly easily with modified equipment. The issue is, obviously, as we discussed, electrons don't penetrate too deeply, so it really limits the types of cancers that can be treated in this mode. As I mentioned, there is such thing as very high energy electrons, and as we saw on that graph, it penetrated very deeply, and it was almost a sort of flat line. The dose rate is pretty even across whatever depth. Unfortunately, this does have the other effect that you're also giving a large dose along that beam line to any tissues that are before or after the tumour. So there is a slight issue there with your very high energy electrons. Most machines currently cannot do these beams yet. There is some work going on at CERN to make VHEE beams. That's quite exciting as well. So then the final type of beam I'd like to cover would be protons. Now, this diagram on the right shows a sort of typical proton therapy bunker. And I think what should be immediately obvious there is it's huge. There is a cyclotron that produces our protons, which then have to be sent round into the treatment area. It is possible to run more than one bunker off a single cyclotron by directing the beam to where it's needed for each treatment in turn sequentially. But ultimately, you're looking at a custom-built building, a very large building. That gantry, I think you might see there, is it says it's a 3-story tall. So this is a massive, massive investment. And this is really what limits the distribution of proton therapy. If we use them, though, they penetrate deeply and they release their energy at a specific depth, which is great for us because it means we are irradiating the healthy tissue along that beam line a lot less other than the tumour. We have to modify current equipment to be able to get these dose rates, but they have been proven in a clinical setting through the FAST-01 trial to be possible, reliable and effective. Unfortunately, due to this massive size and expense of a proton therapy system, it is very limited on how many oncology centres have the room and the budget to install this type of equipment. So, some conclusions. Flash RT, it's showing a massive amount of promise and could completely revolutionise radiotherapy. We're looking at a possible future situation where you can be treated in a single visit in minutes. That would be great for the patients who don't have to keep coming back in day after day to get another fraction of their treatment. And this is great for us in the hospitals and in the oncology centres because we'll be able to see a lot more patients in the same amount of time. The tissue sparing effects could also allow treatment of very sensitive areas, particularly lungs, brains, or any other organs at risk, with a lot fewer side effects. And it has also been proven that you can use Flash RT when you've already reached your limit in dose for conventional RT. And why current technologies can be modified, it's my belief and the belief of others that it is really going to be a new generation of machines. The next generation of machines will be the ones that really utilise this flash effect. Currently, there is a second clinical trial going on, the FAST-02, again at Cincinnati Children's Hospital. This time they are treating bone cancer again, but in the thorax. They have not included the spine in this, and it is currently ongoing. Results should be published soon. Very exciting to see what the results of this are and to see if there was any extra toxicity to the organs in the chest. Yeah, very exciting to see what they are. So thank you very much. Thank you for listening. It was a sort of quick tour through the Flash RT world to give you a bit of an idea of what it is and what's going on at the minute with research in it. Thank you all very much for listening. I have said to Mark about popping the slideshow up, and I have here at the end some links for anybody who want to look into it further. Of course, if you Google it, it's pretty easy to find on there as well. So thank you very much, everybody. I hope you found that informative and interesting. That's all from me.